I'd like to welcome our participants to today's Antimicrobial Stewardship Project webinar series. I'm Dr. Maureen Peterson, the outreach coordinator for the project, which was created by the Center for Infectious Disease Research and Policy at the University of Minnesota. We are pleased to have Dr. Katherine Fleming-Dutra as our speaker today. She will be speaking about her important work and a recent publication to understand antibiotic prescribing and opportunity for stewardship in different outpatient settings. Before we begin, I'll just describe a little bit of Dr. Fleming-Dutra's background. She is, as you see from the title slide there, she's a medical epidemiologist and is the Deputy Director for the Office of Antibiotic Stewardship in the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention, or CDC. Dr. Fleming-Dutra is a pediatrician and a pediatric emergency medicine physician and focused on infectious diseases epidemiology and antibiotic stewardship in the outpatient setting during her career at the CDC. What we'll be describing today is her recently senior authored manuscript in the Journal of the American Medical Association, or JAMA, Internal Medicine. This article compared antibiotic prescribing in retail clinics, urgent care centers, emergency departments, and traditional ambulatory care settings in the United States, and she has some very interesting data to share with you, and I hope that it will stimulate a lot of comments and questions from our participants. To engage with our speaker, our participants, you may notice that at the bottom right-hand corner of your screen is a chat box. We encourage you there to submit these questions and comments in writing, as all lines will be muted during the presentation. The Q&A session will begin immediately following Dr. Fleming-Dutra's webinar today. So with that, I'd like to welcome Dr. Fleming-Dutra to begin her presentation for us.
All right, well, good afternoon, and thank you for having me today. And I guess my disclaimer is the paper I'll be talking about was a 600-word research letter, so I think we may have, I hope we'll have plenty of time at the end for questions for a Q&A session. So as Marnie said, I work in CDC's Office of Antibiotic Stewardship, and I just wanted to put that into the context of how CDC is responding to combat antibiotic resistance. So as you all know, we have lots of activities that are going on and there's lots of activities that are needed to combat antibiotic resistance. And really fundamentally, it starts with preventing infections in the first place, with all the work that we do around vaccines, infection control, keeping people healthy, and preventing healthcare-associated infections when people do need healthcare. We also maintain surveillance for antibiotic-resistant pathogens that are considered threats, and then respond to contain those threats where we've detected them. And then, of course, we work to improve antibiotic use, and that's where our office comes in. And the mission of our office is to optimize antibiotic use in human healthcare to combat antibiotic resistance and improve healthcare quality and patient safety. So as part of that work, we track antibiotic use in all healthcare settings in order to identify opportunities for improvement. I lead our outpatient stewardship efforts, so I'll be talking about the work that we've recently been doing to track outpatient antibiotic use in the United States. And again, the purpose of this work is really data for action, so we want to inform our public health interventions to improve antibiotic use. So antibiotic stewardship, as you all are aware, has been traditionally focused in the inpatient setting, and that's really where the broadest and newest antibiotics are often used and where we're most likely to see our multi-drug resistant infections. So why should we also focus on improving outpatient antibiotic prescribing? And some of you may have seen this graph before, but this graph shows antibiotic expenditures for humans in the United States by healthcare treatment setting from 2010 to 15, and it totaled during that time $56 billion were spent on antibiotic expenditures. Of that, $33.2 billion occurred in the outpatient setting, $16.4 billion occurred in hospitals, and $6.5 billion occurred in long-term care and federal facilities. But we know that most antibiotics used in inpatient settings are much more expensive than antibiotics used in the outpatient setting, or commonly used in the outpatient setting. And so we suspect that the actual volume of antibiotic use in the outpatient setting is likely much higher. And so based on data from other developed countries, we estimate that really 85 to 95% of human antibiotic use by volume occurs in the outpatient setting. So it's clear that our antibiotic stewardship efforts need to also include the outpatient setting. So we have a national goal for improving, antibiotic use. It was set in 2015 with the National Action Plan for Combating Antibiotic-Resistant Bacteria, which was released by the White House. That document contained multiple goals and outcomes that needed to be achieved to effectively combat antibiotic resistance. And in regards to antibiotic stewardship, the National Action Plan contains some very specific outcomes to achieve by 2020, including the establishment of antibiotic stewardship programs in all acute care hospitals and improved antibiotic stewardship across all healthcare settings, and reduction of inappropriate antibiotic use by 50% in outpatient settings and by 20% in inpatient settings. So focusing on that outpatient reduction goal, in order to achieve that, I want to point out that the key word there is inappropriate. And so in order to achieve that reduction, we really need to know how much antibiotic use in the outpatient setting is inappropriate or unnecessary. And at the time that this document was released, we really didn't know the answer to that question. So a couple years ago, we did an analysis to try to answer that question: what proportion of all outpatient antibiotic prescriptions are unnecessary? That analysis was published in JAMA in 2016. And for that analysis, we turned to the data sets that CDC has been using for over 20 years to track antibiotic use in the outpatient setting. The National Ambulatory Medical Care Survey, or NAMCS, and the National Hospital Ambulatory Medical Care Survey, or NHAMCS. So NAMCS is a sample of visits to non-federal employed office-based physicians, and NHAMCS is a sample of visits to emergency and outpatient departments in non-institutional general and short-stay hospitals. These are publicly available data sets that are nationally representative of the visits to the settings that they capture. And as with all data, they have limitations, and a major one is that these data do not capture all outpatient settings. So importantly, these data do not include federal facilities, urgent care, retail health clinics, hospital discharge prescriptions, or telemedicine. But nonetheless, these were the best data that we had at the time that we did this analysis. Another major limitation of these data was that although we knew that an antibiotic was prescribed at the visit that was captured in these surveys, and we knew what diagnosis or diagnoses were listed for that visit, we didn't actually know for which antibiotic or for which diagnosis that antibiotic was prescribed, particularly if there were multiple diagnoses listed. So in order to handle that in the analysis, we developed this tiered diagnostic system to assign a single diagnosis to each visit based on the most likely indication for the antibiotic. So we had tier 1 diagnoses for which we considered antibiotics are almost always indicated. So these are things like pneumonia, UTI, named bacterial infections. Tier 2 diagnoses for which an antibiotic may be indicated but is not always indicated. And you can see the list of diagnoses there. And then tier 3 diagnoses for which antibiotics are not indicated, or there would be not a clear indication. There might be some rare conditions for which there might be a reasonable use of an antibiotic for, but it wasn't clear to us in the analysis. So what we did is if there was a tier 1 diagnosis listed in any coding position, we took that as the diagnosis. If there was no tier 1, then we allowed we looked for tier 2 diagnoses, and then we only assigned tier 3 diagnoses if there were no tier 1 or tier 2 diagnoses present on that visit. So for example, something that I would commonly see as a pediatrician, so a child with a first listed diagnosis of a viral upper respiratory infection, which is a tier 3 diagnosis, and a second listed diagnosis of acute otitis media, which is a tier 2, we would assign acute otitis media as the reason for that visit, because that would be the most likely reason an antibiotic might be prescribed. So with these data, we can then examine when antibiotics are prescribed, which diagnoses are associated with that, and this graph shows in these data what we found. So these are diagnoses leading to antibiotic prescriptions in doctors' offices, hospital clinics, and emergency departments in 2010 and 11. I don't think it's much of a surprise to any of us to see which diagnoses are the major drivers of antibiotic prescriptions, but it certainly was disconcerting to see diagnoses such as viral upper respiratory infections or URIs leading to 5% of antibiotic prescriptions, and bronchitis also leading to 5% of antibiotic prescriptions. And I do want to point out that in these analyses and in the analyses that we just recently did, we only allowed the diagnosis of bronchitis to be assigned in visits without additional diagnosis of chronic obstructive pulmonary disease, chronic bronchitis, or emphysema. So by comparing these data to the National Clinical Practice Guidelines, we were able to determine or estimate what proportion of antibiotics prescribed to patients in these settings are unnecessary. And for this process, we included estimates of unnecessary antibiotic use in sinusitis, acute media, and pharyngitis, which may legitimately sometimes need antibiotic treatment, as well as targeting no antibiotics for conditions like viral URI and bronchitis. And when we do that, we estimate that at least 30% of antibiotic prescriptions written in these settings were unnecessary, meaning that no antibiotic was needed at all. These unnecessary antibiotic prescriptions put patients at unnecessary risk of harms from adverse reactions and C. difficile infections. And we found that respiratory infections, such as sinusitis, colds, and bronchitis, were major drivers of this unnecessary antibiotic use. And so putting that into the context of the national goal we estimated that our national goal was to achieve a reduction of overall outpatient antibiotic use by 15%, or half of the unnecessary 30% by 2020. But even as we were doing this analysis, we had to acknowledge this major limitation that we were missing a big part of outpatient antibiotic use in these data. And so we knew that going into this, but how much were we missing? We actually have data that can tell us that the total number of antibiotics dispensed in U.S. outpatient pharmacies. And so we know in 2011, there were 273 million antibiotic courses dispensed in U.S. outpatient pharmacies. Using the NAMCIS and ENHANCIS data that we just discussed, we knew what percent came from doctors' offices, about 42%, from EDs, about 9%, and hospital-based clinics, about 5%. We also know how many prescriptions are written by dentists. That's about 9% of antibiotic prescriptions. And then we have this other bucket that really accounts for just over a third of outpatient antibiotic prescriptions. And so we hypothesized that urgent care centers and retail health clinics could be major contributors to this other bucket. And we really wanted to better define antibiotic prescribing in these other settings so that we could understand where we might have additional opportunities for improving antibiotic use in those settings and make sure that we're including these other settings in our outpatient stewardship efforts. So it's important to point out that urgent care and retail health are not the only other settings, or the only settings in that other category that we weren't capturing, but we certainly thought that they were likely very important settings when it came to outpatient antibiotic use. So getting up to the more recent study that we just published, we were able to get access to claims data to better explore these other outpatient settings. We used the 2014 Market Scan Commercial Claims and Encounters database. This is really a convenient sample of individuals and their dependents aged less than 65 years who are covered by employer-sponsored health insurance. That's reported into Market Scan. We excluded visits by patients who did not have drug coverage that was captured in Market Scan, and we did this in a window around their visit, so the month prior to or following the visit, with the exception of visits that occurred in December 2014. We did not move into the 2015 data to make sure they still had drug coverage. And so we might have missed an antibiotic prescription that was filled in 2015 for a visit that occurred in late December 2014. We excluded visits that didn't have any listed diagnoses, because otherwise we wouldn't be able to assign a diagnosis to it. And then we excluded visits that had a claim for hospitalization within 30 days prior to their visit or on the same day of their visit. And then we excluded patients who had a systemic antibiotic filled within 30 days prior to their visit. We used the medical claims part of the data set to identify medical visits. We selected visits with a facility code on the medical claim of retail health clinic, urgent care center, emergency department, or office, and we analyzed each setting separately. Then we used the pharmacy claims to identify systemic antibiotic prescriptions. This means that we only captured antibiotics that were dispensed at a pharmacy and paid for by drug coverage. So we would miss free or low-cost antibiotics for which drug coverage wasn't filed by the pharmacy, and we would miss antibiotics administered at the visit or samples given at the visit. We had to make a number of assumptions, and one of the key ones is to be able to link the antibiotic from the pharmacy claim to the outpatient visit. So for oral antibiotics, we did that within a window of time We assigned an oral antibiotic to the most recent outpatient visit within 3 days of the fill date of that antibiotic. And we did look to see how many of those antibiotics were filled on the same day as the visit, because we felt most confident about antibiotics filled on the same day of this visit that we were assigning it to the correct visit. So for urgent care centers, 96%, 96.3% of antibiotics were filled on the same day. For retail health clinics, it was 97.2%. For offices, it was 90.9%. And then for EDs, it was lower at 71.1%. And we don't know for sure why this is, but we hypothesize that it has to do with the 24-hour nature of an emergency department, and a certain proportion of patients would be seen late into the evening, potentially discharged close to midnight, and might fill their antibiotic quickly after the visit, but not until after midnight the next day. For parenteral antibiotics, we assigned them to the outpatient visits only on the same day. But this was very uncommon in the data, and that's to be expected because, again, we're picking up antibiotics that are dispensed at a community pharmacy. Parenteral antibiotics are usually not dispensed, most often would be given during the visit and not dispensed from a pharmacy. Another assumption we had to make was to assign each visit a single diagnosis based on the most likely antibiotic indication, and we used the same tiered ICD-9 code diagnostic system that we used in our previous JAMA paper, which is why I spent a bit of time talking about it a little bit earlier. So again, just as another example, if a patient had a visit with the first listed diagnosis as viral upper respiratory infection or URI, and a second listed diagnosis of acute otitis media, again, acute otitis media would be the assigned visit diagnosis. We then, for this analysis, focused on visits for antibiotic inappropriate acute respiratory illnesses or ARIs. This included bronchitis, and again, for bronchitis visits specifically, we excluded any visits that had additional diagnoses of COPD, chronic bronchitis, or emphysema. And then that antibiotic inappropriate ARI category also included viral URIs, bronchiolitis, influenza, non-suppurative otitis media, asthma and allergy, and viral pneumonia, which we had done in previous analyses. I will point out that that viral pneumonia code is very rarely used in the data. So what did we find? So this graph shows the number of visits with antibiotics prescribed by setting in the blue bars, and the percent of antibiotic prescribing per visit by setting in gray. So what you can see is that urgent care and retail health clinics commonly prescribe antibiotics at a per visit rate. So 39% of visits at urgent cares resulted in an antibiotic prescription and 36% in retail health settings. And this likely has a lot to do with the case mix of patients that they're seeing. But the biggest volume of antibiotic prescriptions was actually coming out of medical offices, which likely reflects, again, the huge volume of visits to this setting. This was by far the largest number of visits. Only 7.1% of office visits result in antibiotic, but it was more than 10.5 million antibiotics. But given the different case mixes that that are seen in these different settings, it's hard to draw many conclusions from these results alone. So then next we focused, again, on the antibiotic prescribing for antibiotic inappropriate acute respiratory illnesses or ARIs. And just as a reminder, these include viral URIs, bronchitis, bronchiolitis, influenza, non-suppurative otitis media, viral pneumonia, and asthma and allergy. And remember, these are visits that do not have any Tier 1 or Tier 2 diagnoses listed. So these patients don't also have diagnoses of pneumonia or UTI or sinusitis or et cetera. So the blue bars, again, show you the number of visits for antibiotic inappropriate respiratory conditions that got antibiotics, and the gray bars show you the percent of visits for antibiotic inappropriate respiratory conditions that received antibiotics. And remember, for all these settings, the percent of visits for these conditions that are receiving antibiotics should really be 0. But you can see that all of these settings have opportunities to improve antibiotic use or antibiotic prescribing for these conditions that don't need antibiotics. So in urgent care, 45.7% of the visits for these antibiotic inappropriate ARIs resulted in antibiotics, 24.6% in emergency departments, 17% in offices, and 14.4% in retail health clinics. So again, all settings absolutely have opportunities to improve antibiotic use. We did see the highest percentage of prescribing for these conditions in urgent care, but the highest volume is actually out of medical offices. So we clearly need to be engaging all of these settings in stewardship efforts. And then if we look at this by diagnoses for the antibiotic inappropriate ARIs, and I did not include viral pneumonia on this chart because, again, it was very uncommonly used. But you can see we've changed the way the graph is, and now urgent care is shown in the blue bars, retail health in the purple, emergency departments in the yellow-orange, and offices in the red, and then the conditions on the x-axis. And again, this is percent of visits with an antibiotic prescribed. And so you can see that we see a similar pattern for urgent care with a higher percent of antibiotic prescribing for each of these conditions. When we look at the medical offices, actually they prescribe a higher percent of antibiotics for upper respiratory infections than EDs and retail health, same with bronchitis and influenza. But the medical offices actually had the lowest prescribing for asthma and allergy and non-suppurative otitis media, which might reflect the fact that they do a lot of chronic management of these conditions and maybe seeing them when they're not acutely sick. So, of course, these data have limits, and our analyses have limitations. As I mentioned, this is a convenient sample. It is not nationally representative, and it's limited to a population of insured individuals under age 65. I think, importantly, we really don't know whether the capture of each setting is representative of their actual market share. We did note that the number of retail health visits we captured were quite low, as well as urgent care compared to the estimates of how many visits they have nationally. We know that these data do not capture telephone encounters, and so there is a possibility that we could have misattributed an antibiotic prescription in the case of where a person had an in-person visit at one setting, but then after leaving that setting may have called another provider and received an antibiotic prescription over the phone. We would have no way to capture that. We did not evaluate telehealth or virtual visits. We know that, again, as we talked about, the data only capture medical visits paid with insurance claims and dispensed antibiotics paid for by the drug coverage. We were limited to the coded ICD-9 diagnoses, and it's very important to note that we were unable to verify the accuracy of these diagnoses with these data. And then, of course, we did not assess antibiotic selection, dosing, or duration, and I'm sure as many of you know, there are a lot of opportunities to improve antibiotic selection, dosing, and duration in the outpatient setting, as there are in many across the spectrum of healthcare. However, a strength of these data is that in this study is that this is a very large data set that allowed us to capture and examine antibiotic prescribing in healthcare settings that we were previously unable to examine and that weren't captured by the other data sources we've been using to track antibiotic use in the outpatient setting. And so I think despite the limitations, I think it is clear from the study that there are opportunities to improve antibiotic use in all of these settings that we studied. So what's next? I'm sure you all know the answer, but we need antibiotic stewardship implementation in all of these settings. Many of you are aware, but CDC has the core elements of antibiotic stewardship for settings across the spectrum of healthcare. There's the hospital core elements, the nursing home core elements, and in 2016, we released the core elements of outpatient antibiotic stewardship, which are really our guidance on outpatient stewardship and provide a framework for implementing antibiotic stewardship in outpatient practices. I'm sure you're aware, but the core elements of outpatient antibiotic stewardship include commitment, demonstrate dedication to and accountability for optimizing antibiotic prescribing and patient safety, action for policy and practice, to implement at least one policy or practice to improve antibiotic prescribing, assess whether it's working and modify as needed, tracking and reporting, to monitor antibiotic prescribing practices and offer regular feedback to providers, or have providers assess their own antibiotic prescribing practices, and education expertise to provide educational resources to providers and patients on antibiotic prescribing and to ensure access to needed expertise in optimizing antibiotic prescribing. And the document is really meant to apply to outpatient clinics that, or in outpatient facilities that prescribe antibiotics, including primary care, outpatient specialty and subspecialty clinics and clinicians, emergency departments, retail health clinics, urgent care clinics, and even dentists. So what we really need to do is help is to get uptake of these core elements in all of these settings that we talked about. So one way that we are doing this is actually with the help of partners. So the Quality Improvement Network and the Quality Improvement Organizations, or the QINQIOs, if you're aware, are implementing the core elements of outpatient stewardship. So the Center for Medicare and Medicaid Services, or CMS, tasked the QINQIOs to implement CDC's core elements of outpatient stewardship. Actually, in 2016, they were tasked with that. And the QINQIOs work regionally to help disseminate best practices and improve clinical quality and patient safety. So as of January 2018, the QINQIOs nationally have recruited over 7,600 outpatient facilities, including over 5,900 physician practices, 748 hospital emergency departments, and 470 standalone emergency rooms or urgent cares to implement the core elements. And the QINQIOs are providing technical assistance to these recruited facilities to implement antibiotic stewardship. So I just want to highlight one success story that we've heard from the QINQIO work. So one urgent care program that enrolled with their QINQIO to implement the core elements is Christiana Care Medical Aid Units. They are a Delaware-based healthcare system that has over 5 urgent cares that they call medical aid units that have over 30 providers and 70,000 visits a year. They implemented their antibiotic stewardship program in January 2017, and it was led by Dr. Kramer, who's shown in the picture here. And they use the core elements as their framework. They really determined what their preferred antibiotic treatment regimens would be for the common conditions that they see, and they based that on national clinical practice guidelines. And then they started performing chart reviews and reporting back to their providers on the progress on meeting those guideline recommendations, as well as compliance with the recommendations. And they also distributed educational materials to providers and patients. So you can see they really did all of the core elements. And in February 2018, they were prescribing 39% less antibiotics per visit than they had been in January 2017 when they started their program. And so Dr. Kramer authored a really nice blog on the Safe Healthcare blog website that's available at the link here, so I encourage you to take a look at that. And I also want to take a minute to highlight that CDC also has a national educational effort to educate the public and healthcare providers about appropriate antibiotic use in order to improve antibiotic prescribing and to fight antibiotic resistance. I'm sure you've all heard of it, but it's Be Antibiotics Aware, Smart Use, Best Care. And we at CDC recognize that public education is a critical piece to improving antibiotic use. One of the things that we often hear from clinicians is that they perceive that patients expect or demand antibiotics, and that we know that that is one of the drivers that leads clinicians to prescribe antibiotics when they may not be indicated. And CDC has led educational efforts to improve antibiotic use actually since 1995. Those early efforts were really focused on improving antibiotic use in children, and over the years they have expanded to include all ages. But in 2017, we rebranded, and the new educational effort is called Be Antibiotics Aware, Smart Use, Best Care, and that effort has increased messaging for adult patients and new efforts to reach clinicians who care for adults, including urgent care clinicians. And then additionally, CDC has incorporated antibiotic stewardship messages into other related educational efforts. So, for example, CDC's Get Ahead of Sepsis educational effort has stewardship messaging embedded within that educational effort as well. And then lastly, I want to let you know that we have a new continuing education training on antibiotic stewardship. It's mostly focused on outpatient antibiotic prescribing, although not entirely so, but that's the main part of that training. And it's really aimed at frontline providers, including those providers who would work in urgent cares, retail health clinics, medical offices, and EDs. The objectives of this training is to optimize antibiotic prescribing, to inform healthcare professionals about proper antibiotic use, and to encourage open discussion among clinicians and patients. And one of the things that I'm really excited about is this training has a module that includes communication training for clinicians about how to efficiently and effectively communicate with patients when antibiotics are not indicated. This training has 8 hours of free continuing education available to physicians, nurses, pharmacists, certified health educators, and public health practitioners. Sections 1 and 2 are available now, and 3 and 4 will be coming online in the next month. And this training actually fulfills improvement activities Patient Safety and Practice Assessment, so PSPA 23 and 24, for those of you who are familiar with that language, under CMS's Merit-Based Incentive Payment Program, or MIPS. So it's available at the link here, and we have a flyer if you're interested in helping us promote that course. I'd be happy to send the flyer to anyone who would be interested in helping us promote that. So in summary, all of these outpatient settings, urgent care, emergency departments, medical offices, and retail health clinics have opportunities to improve antibiotic use. Urgent care centers prescribe the highest % of antibiotics for antibiotic inappropriate ARIs, or acute respiratory illnesses, but we also saw that medical offices prescribe the highest volume of antibiotics for antibiotic inappropriate ARIs. We need to make sure our stewardship efforts are really including all of these settings. We did see substantial variability in the % of visits by setting leading to antibiotics, and this likely reflects differences in the case mix by setting, as well as differences in overuse of antibiotics for antibiotic inappropriate respiratory illnesses. We know that unnecessary antibiotic use in all outpatient settings, well, we know that we saw in this study that it was that there was a significant proportion of these antibiotic inappropriate ARIs in urgent cares that were treated with antibiotics. So we actually think that unnecessary antibiotic use in all outpatient settings may be actually higher than the 30% we estimated in that JAMA paper that was based on doctors' offices and emergency departments. And then lastly, antibiotic stewardship is needed in all of these settings to improve antibiotic use, and CDC's Core Elements of Outpatient Antibiotic Stewardship provides a framework for implementing stewardship in these outpatient settings, and we're already seeing success stories of settings using the core elements and improving antibiotic use, which is very exciting. So with that, again, as I said, it was a research letter that we were talking about today, so not quite as much to talk about for a full hour, but I'm happy to take any questions, and I do want to tell everyone to please mark your calendars for U.S. Antibiotic Awareness Week, which will be November the 12th through the 18th this year, and there'll be lots of stuff coming out, and it's a very exciting week, so I hope you'll all participate. With that, Marnie, I'll turn it over to you to moderate the Q&A.
Terrific. Thank you so much, Katherine. That was a really nice overview and summary of your historical data and then the most recently published and available manuscript. And the participants, if you want to, this is your time to engage with Dr. Fleming-Dutra, so please feel free to send us your comments or questions to her in the chat box. So I have a few questions in listening to the webinar to kick it off here. Well, one is just to ask you to elaborate a little bit more on this data set versus historical. I know you talked a little bit about it, but the Truven Health Market Scan data set, can you just describe that a little bit more to our participants so they're aware of where this came from?
Sure. So the Market Scan data set is, so Truven is a company that produces this data. It's actually de-identified claims data from a number of employer-sponsored health insurance plans. We do not know who the health insurance plans are that report into this data set, but we do know that it is biased towards larger employers that report in, and then it reports in their medical claims, so it's billing data. And then with certain participants, many participants, not all though, we also get their drug coverage, which is why it's so critical to make sure when we're doing these analyses that we're limiting it to those individuals that have both drug coverage and medical coverage. And then the benefits of this data is it allows us longitudinal. You can, even though it's de-identified, you can track individuals over time within the data. And then using the medical claims, we're able to identify the facility type. So when the claim is submitted, there'll be a facility code that identifies it as an urgent care center or a primary care clinic or medical office or a retail health clinic, if that makes sense. So there's a facility code there. And that, my understanding is that that facility code is tied to kind of their copays and how it's billed. So they may not be perfect, but that's how we identify facilities.
Thank you. One of the questions from our participants is describing the biggest issue faced in implementing the outpatient antimicrobial stewardship programs is obtaining funding for the resources, and predominantly because it's difficult to prove the cost savings, and so they tend to use the inpatient side. The question is, what innovative methods have been used in this setting? Are you aware of some of these that you could share?
Yeah, that's a great question, and I think you it gets to an issue about it is hard, I think, in the outpatient setting to demonstrate the cost savings, and it depends on who you're demonstrating the cost savings to. So in the inpatient side, you can look at the cost savings to the hospital of both funding the work that the antibiotic stewardship program does and the people that work on that program, and then what they saved by, not using certain drugs or, reducing their use of these high-cost antibiotics. In the outpatient setting, it really doesn't impact the physician in the same way. The cost of the antibiotics really isn't something that plays into the physician's, I guess, compensation, or it's not really something that affects them, maybe is the right way to put that. So that cost is really more on the payer standpoint. And then, similarly, the adverse events are harder, I think, for the clinician who initially prescribes the antibiotic. They may not even know if the patient, particularly in emergency departments or urgent care settings for regional health where they're not the primary care physician, they may never know if a patient gets C. difficile or an allergic reaction or things like that. So it depends on who you're looking at, but I think on the national scale, certainly inappropriate antibiotic use, there's costs associated with prescribing drugs that aren't needed, and then there's costs associated with the adverse events and potentially resistant infections down the line. And we're certainly very interested in our program trying to better understand what those costs are, but it is a work in progress. I think from the standpoint of getting resources, I don't know that I have the answer, the magic bullet, but I think the QuinnQIOs have been really, a great, they've really worked hard on stewardship, and they're helping these settings implement, which has been great in providing some of that technical expertise to help. And I think it's really, in the outpatient setting, our hope is that it will be embedded within the quality programs and quality improvement initiatives that we hope that all outpatient settings have. And I see that as kind of, I think, the model that will be most beneficial, and that's how Christiana has done it, and other groups that I've talked to that have been successful that have done this as part of their quality improvement initiatives. I don't know if that's the best answer, but I think we'll learn more as time goes on.
Yeah, it seems also, excuse me, you might be able to get support from the employers or, those that are, especially the sponsored programs, to try to sponsor these programs such that they could potentially have impact and save costs there. But I guess stay tuned. Another question I think that a lot of the participants will find helpful is someone who is currently in process with another stewardship colleagues or with colleagues. They're collecting internal ambulatory prescribing data for a large integrated health system, and they're trying to determine a meaningful metric for ambulatory antibiotic consumption. An example being the number of antibiotic prescriptions per 10,000 encounters, but they're struggling with what that denominator should be. Any thoughts on that, and what to measure?
Yes, no, I think it's a great question, and something that maybe the outpatient setting has even less well defined than the inpatient setting. So I guess the number of antibiotic prescriptions per visit or encounter, I think I think the answer is that probably we need to be measuring multiple things. I think, certainly percent prescribing for certain key conditions where antibiotics are not needed is, a great place to start. So looking at non-specific upper respiratory infections or viral upper respiratory infections, acute bronchitis, where there's clear targets of antibiotics just aren't needed, is a good place to start. But then that also brings up the question of those metrics are fairly easy to game, in that someone can just sort of shift a diagnosis and write down a diagnosis for which an antibiotic might be indicated. And so I think tracking both of those together, both the percent prescribing for conditions that antibiotics aren't needed for and sort of total antibiotic prescribing can help address that issue, if that makes sense. So if you see your upper respiratory infection prescribing going to 0, but no difference in your total antibiotic prescribing per visit, that might be a signal that some diagnostic shifting has gone on. So I think that's probably a place to start. I'm sorry I didn't include it in the presentation, but there's actually there's a really nice toolkit called the Mitigate Toolkit that Larissa May and colleagues out at the University of California, Davis, and some other sites out in California put together on antibiotic prescribing or antibiotic stewardship interventions in the emergency department and in urgent care settings. And I can share with Marnie that link. But they have put together kind of a metric of again, respiratory conditions for which antibiotics aren't needed, with matching ICD-10 codes that, could be a really nice place to start. But again, I would pair that with looking at your overall antibiotics per encounter, or per 1,000 encounters.
I think that leads to a follow-on question that we've received as well from our participants, and I thank them for submitting them. It talks about the diagnostic uncertainty and how that drives over-prescribing. And this particular participant mentions their qualitative work suggests that this plays a significant role of determining whether the diagnosis of bronchitis or pneumonia, as the chest X-ray is an imperfect diagnostic test. Physical exam findings are often unreliable. So the question is basically a follow-on to what you just mentioned, is do clinicians need to make sure their ICD codes match the prescription, basically?
Right. I think it's a great question. I think ideally clinicians will be documenting the diagnosis for which they intend the antibiotic. You could argue whether that needs to be their coded diagnosis or the diagnosis they write in the chart. But ideally, I think that's what we hope for. I think we can all recognize that is not going to happen in every encounter 100% of the time. But, I think that makes certainly the tracking and reporting end a lot easier for the stewards that are doing that piece. So it's a good question, and I think, we do know, as you said, that diagnostic uncertainty really is something that plays into physician or doctors and clinicians prescribing antibiotics when they're not needed. They may be worried about something bad happening to that patient, and I think we just have to be. And that's a legitimate concern in certain patients' circumstances, but I think we also have to just be very mindful that antibiotics are not without risk. I think we all know that, but they have adverse events. They can lead to C. difficile infections. They can lead to later antibiotic-resistant infections for that, higher risk of those infections for that patient as well as for the community. And so I think, the other side to that is helping clinicians and patients realize that there is a risk to giving antibiotics, so we want to make sure we're carefully weighing those risks and benefits and communicating that well to patients, I think, is another important piece of that. I think there's been a perception for a long time that why not just give the antibiotic, and I think we have to help make sure that conversation is informed by the actual risk and benefits of the medications.
Right. Another follow-on comment from another participant is, they mentioned excellent work, your latest manuscript, but wanted to know a little bit more about the Tier 3 coding. Did you exclude the symptom-based Tier 3 coding from the more recent analysis?
So the coding system, and particularly in the claims data, it's the only thing that you have to rely on is the billed codes. If they're talking about things like cough and I can share that the coding system actually was in the supplement to that original JAMA paper. So there are a couple of symptom-based codes that I believe I'd have to double-check ended up in some of those, the non-specific URI, things like cough with no other, just cough. But for the most part, the symptom-based coding are falling into, they're technically Tier 3, but they're falling into the all other, and so they're not going to be brought up into that antibiotic inappropriate ARI category. That's a little bit complicated, but the tiered system was a way analytically to sort of rank the diagnoses, and then we pulled out specific categories within Tier 3, bronchitis, bronchiolitis, URI, if that makes sense, to do that more focused analysis on the antibiotic inappropriate ARIs.
Another question is just sticking with the manuscript itself. In some of these settings, I forget what slide number it was, but you had one of your first data slides where you described the total percent of antibiotic inappropriate ARIs with antibiotics. And in the emergency department, the physician's offices, and the retail health setting, it was all, 15 to 25% of those prescriptions were inappropriate. The question is, is that trending downward, do you think? Since the data from 2011, do you feel like some of the campaigns are having an effect?
Yeah, so that's a great question. It is a little bit tricky, and we have been working on updating the analysis with the NAMSIS and ENHANCIS data, and we will be working on trending the market scan analysis in future years. I think part of what makes that a little bit tricky is that we have seen that the growth of these settings, urgent care and retail health clinics, that are not captured in the data set we used in that original 2016 JAMA paper. So it makes it a little bit difficult to compare over years. But that being said, I will say that we have had some success in reducing overall outpatient antibiotic use, and let me see if I have some extra slides that may be of use. So if you'll bear with me, I'm going to scroll forward. So we use to track overall outpatient use in the United States, kind of the total use. We look at antibiotic suspense in U.S. outpatient pharmacies, and this data is from IQVIA, and we publish this on our website. So if we look at overall outpatient antibiotic rates per 1,000 population from 2011 to 2015, in which we at the CDC have comparable data sets, we see that we've had a decrease of about 4% during that time frame in outpatient antibiotic prescribing rates. However, if I split that out or stratify that by age category, so this is the same graph showing the antibiotic prescription rate in outpatient settings per 1,000 population, but kids are shown in the orange bars, 0 to 19 years of age, and then adults 20 years and older in the blue bars. And what you can see is that outpatient antibiotic prescribing rates to kids have decreased by 13% during that time, and basically rates to adults have been stable. So what we see in the overall data is that really the improvements that we've seen in the first part of this decade have really been driven entirely by children. And so that was another piece of data that we had to that signaled to us that we needed to make sure that our new educational effort really had messaging that was targeted at adult patients.
Thanks for the additional slides. That's really helpful. I know in the study you mentioned that you excluded anyone over age 65. Was that just because of the nature of the database you were working with?
Yes, great question. So the market scan data captures individuals under age 65, and they don't include individuals over age 65. But potentially you could use Medicare data to try to look at that population a little bit more carefully.
Okay, great. I really appreciated the urgent care success story, the Christiana Care example. So I have a question. In their core element framework, you mentioned that they basically they determined their preferred antibiotic regimens. And so I have a question, and maybe it's a follow-on paper. Of those antibiotics that were prescribed appropriately for the diagnosis, have you dug deeper to determine is that a first-line antibiotic for that particular diagnosis? Like what percentage of those that are, okay, the indication warrants an antibiotic, but perhaps not that antibiotic?
That's a great question, and for the Christiana Care story, I will refer you to Dr. Kramer, who's the one leading that program and looking at their data. And you can also look at the Safe Healthcare blog. He did note in that blog that they specifically targeted azithromycin use as well, really around that same question. It's not recommended as in the sinusitis guidelines for treatment of sinusitis or otitis. It is recommended for pharyngitis for patients with penicillin allergy, but for some of their common conditions, shouldn't really be a commonly used antibiotic. And then they did see reductions in azithromycin use as well. In the national data, we have looked at that as well, and you're absolutely right. There's significant need to improve selection of antibiotics to be in line with first-line recommendations for common conditions like pharyngitis, sinusitis, and otitis media.
All right, we have 2 more questions here so far. I think we can fit them in. It relates to, you have a goal to reduce the inappropriate prescribing, basically cut it in half to 15% over the next basically 2 years that you have remaining, or a year and a half. And so the question is, does the CDC have plans to do a large-scale, basically public safety awareness campaign to increase the public's understanding? Because I think that that's going to be a critical component here as well.
So yes, so our Be Antibiotics Aware Smart Use Best Care educational effort really is a public educational effort. So it's aimed both at providers and the general public, and that's where we have a lot of materials and messages aimed at the public before they become patients, even to educate them about appropriate antibiotic use, when antibiotics are needed, when they aren't. U.S. Antibiotic Awareness Week is our big push to try to get those messages out, and that actually is timed. It's the same week as the WHO's, the World Health Organization's Antibiotic Awareness Week, as well as European Antibiotic Awareness Day, and Canada has an observance week that week as well. Lots of international activity that week. That being said, we do our absolute best to get these messages out, but we try really hard, but we end up needing to depend on partners a lot to increase our ability to disseminate these messages. So an ask I would have for all of you all is to participate in U.S. Antibiotics Awareness Week, to look on our website. We have a really nice video that, I'm sorry I didn't show today. And the antibiotic is, it's called The Right Tool, and it's about an antibiotic's not the right tool for a viral infection. So materials like that, we really hope that our partners are picking up and helping us disseminate that so we can get those messages out to the public.
All right. I guess I'm just looking at the last question here. There is a comment that there are mass media campaigns viewable without the patient population having to go look for it. So maybe something that's even more readily available to the population, that is almost like commercial or that type of getting in through that type of media, television or that sort of thing. There's a suggestion from one of the participants.
Yeah.
All right, I have two questions, and then we're going to have to end it. So the one is regard to the, is there a plan at the CDC to use a similar national healthcare safety network like reporting of antibiotic use for the ambulatory setting?
That's a great question. So the National Healthcare Safety Network, or NHSN, surveillance network is run out of our surveillance branch, so I might refer some of those questions to them. Currently, outpatient facilities like primary care facilities, urgent care clinics are not reporting into NHSN, so I think anything like that, that system right now doesn't capture those settings, so I think anything of that nature would be quite far down the line, because we're not currently capturing any data from those types of settings in NHSN.
Okay. And so the final question relates to also encouraging perhaps shorter duration of antibiotic treatment regimens as those studies become available.
Yes, it's a really great question, and I have an extra slide. I have another extra slide. So some of you may have seen a recent research letter in JAMA IM from our team looking at duration of therapy for sinusitis. As you all are probably quite well aware, IDSA recommends 5 to 7 days of therapy for patients with uncomplicated acute sinusitis when antibiotics are needed. As we all know, many patients with sinusitis don't even need antibiotic therapy, but some do. But we looked at the duration of therapy in a different data set, not market scan, looking at mainly physicians and offices, and found that by far the most common duration was 10 days. And there were some, significant proportion of patients treated with 5 days, but that was almost all azithromycin, which, as you know, is not a recommended treatment for sinusitis, and also has an extended half-life, so doesn't really is not really a shorter course antibiotic therapy. So yes, I think shortening duration to the minimum effective duration is a really key stewardship strategy, and something that we're really trying hard to make sure is part of efforts to implement the core elements, and part of our messaging to patients and healthcare providers. But again, we need a lot of help from our partners to get those messages out.
Excellent. Well, thank you so much, Dr. Fleming-Dutra, for a very thorough Q&A session today, and that's really also due to all of our participants that submitted your questions, which were all very good, and we appreciate that a lot. I want to remind all of you that the webinar was recorded, and we will be making this available within the next couple of days on our website, which you can see there in the chat box, that link to our website. So please check it out, and our other webinars from our series are available there as well for your viewing at your leisure. So thank you, Dr. Fleming-Dutra, and terrific work.
Thank you so much for having me.
Have a good day, everyone.